Thomas Clinton. I am a second-year resident in internal medicine here in the United States, and yeah, I already have some residency experience in Costa Rica. So tomorrow I have to present this lecture. This is an evidence-based medicine lecture, and I would like to share it with you guys. And if I don't record it right now, I might not record it later. And I think that basically any human being breathing and eating today might benefit from learning one or two pointers from this. So I'll try to make it short and sweet, which isn't usually my thing. I usually talk a lot. So let's go right into the action. So what makes me want to talk about the fog? So the title for this presentation is The Fog. You'll see why later on. And well, I have two older parents, which could actually be my grandparents. So I would remember when I was like 5 or 6 years old that people would tell my parents like, oh, I love your grandson, he's so nice, and like I'm playing in the playground, and they would say like, oh, your grandson this and that, and I'm like, no, they're my parents. And I would listen to this and I would look at these people like pissed off with them. Why? Because this made me generate a sense of time constraint. I understand that time is limited, so I understand that my parents already had me at an older age, so this made me much more conscious about older age individuals and how we have to take care of them. So we have to take care of them, and they're part of our society, and if we have a good healthcare system, all of us will eventually be old, and we would like to be respected when we are old. So my parents are doing quite fine, I thank God for it, but that's one of the motivations, because the fog is something that happens usually at old age. So the main motivation is one of my friends, a friend I have here, or I had here with my wife in Savannah. We met him in Savannah, Georgia, and it all started basically after we figured out he wasn't recognizing us, or he wasn't remembering us. We would always meet him at the dog park, or we would just run into him there, and he would forget our names. He would forget that I was married if I went there alone, and he would forget this and that, but he would always recognize that our dogs were pretty neat, pretty nice. And I started thinking about this with my wife, and we thought that he was maybe a little forgetful. When we knew this was an actual thing is when I gave him my phone number so he could call me if he needed any help whatsoever. He was reaching probably his late 70s, and yeah, he started calling and calling every single day, and I figured out that he was forgetting. He was calling me the day before, so that's how we noticed that he was definitely forgetting a whole lot of stuff. And it felt like 51st dates. I didn't think that this was something you could actually sort of experience, where someone just forgets completely about you till the next day. And it was interesting because he was like fully functional. He would walk his dog to the park, and then would come back, and he would sort of cook himself some food, and yeah, was just enough functional to get out of home, run a couple errands, and get back home. But he was completely forgetting about us. So this is something that motivated me to talk, in this case, about neurology over what I usually choose, which is cardiology, which is another of the passions I have. So he told me he was getting a shot in the VA, and I thought about that, and I was like, you probably are confusing the medication with something else, because I couldn't think of any shot you can receive that will help you with this fog, which is called dementia, and in this case, Alzheimer's. So in the end, I saw that in 2023, late 2023, we have an article from the New England Journal of Medicine talking about a medication which has been in trials, undergoing trials, and currently is phase 3 trial, which is lecanemab, which is an injection, and also the VA was part of these trials. So probably he was telling me about this medication, which I knew afterwards. So that was pretty interesting, and that's part of why I want to talk about this today. So you already know the problem. The problem is the fog, and the fog is Alzheimer's, which is the main manifestation of dementia, right? Or it's the most common form of dementia, costing approximately $400 billion yearly to taxpayers while we search for a cure, but before that, how to stop its progression in its tracks. So it is growing a lot, and as you can see right here, the pyramid of population densities per age has changed and will change a lot. So it was a pyramid in the 1960s. Now we won't be able to call it a pyramid anymore. And as we advance into the future, lifespan increases, but not necessarily health span. At least the health span of the brain has an increased comparative, for example, to the health span of the heart or the health span of a patient with HIV. There's a lot of discordance. While a patient with HIV nowadays, there has been a reduction of about 60% mortality because of the advancements in treatment. In Alzheimer's, there has been an increase of mortality to almost 150% because we haven't advanced much and haven't had much success in Alzheimer's research in the past decades, right? So it has been less successful than cancer research, 99.6% failure rate for trials. That is saying a lot. So this leads me on to my investigation question, which is surrounding our friend, which is in elderly patients with advanced Alzheimer's disease, which management strategy can delay or reverse the progression of the disease? So that's how I made my PICOS table, which is how I will try to appraise or search the medical databases to see what information we find. So we already talked about the population. We are searching. We already talked, well, intervention. It can be a pill, an injection, non-pharmacological, lifestyle change, whatever helps. Comparison is to standard care or other management strategies, and the outcome is to delay or reverse progression of Alzheimer's. Timing, whatever is out there, but I had to choose maybe 6 months, a year, 2 years of these trials, okay? And the setting, well, inpatient setting, outpatient, whatever we could find. So this took me on to my journey with this Alzheimer's treatment investigation, and we can see right here that basically all these different treatments up to date that reduce symptoms have just reduced symptoms modestly. We're talking mainly about the acetylcholinesterase inhibitors. These three that you can see right here are the medications I just mentioned, and also would add memantine. Memantine is, or also known as Namenda, is the brand name, is also used, which can be used for moderate to severe Alzheimer's, but once again, the evidence is just modest and even conflicting results. So yeah, use it because it might help a little bit and it might help some people, but for the grand majority, it has shown modest, if any, improvement. So here I'm just remembering that one of my fellow colleagues or co-residents presented about vortioxetine, which is an SSRI, and trying to see if patients with Alzheimer and dementia, which usually go together, if there's any improvement. In the end, it didn't show any improvement, which isn't any surprise. So now let's go into the area of disease-specific therapy. So those therapies we were talking basically went more indirectly against Alzheimer's, and these will go against what we think is the main culprit, which is basically called the amyloid hypothesis of disease, which is that in Alzheimer's brain, as you can see here in the middle, there are neurofibrillary tangles here in these neurons, which are just clumps up in the neuron. They are in the cell, in the neuron, and out of the cell or extracellularly, you can see these amyloid plaques. So this is mainly made of amyloid, and the neurofibrillary tangles made of some protein they named tau. And here you can see a normal brain on the left, and on the right, you can see the affected brain with Alzheimer's. So following this hypothesis, what did they do? They basically did a vaccine in 1999, this Elan pharmaceutical, which the idea was to inject synthetic beta amyloid into the person and just expect the person to generate antibodies against it, and voila, fixed, cured. Well, that wasn't that simple because there were a whole lot of side effects, and 6% of patients developed brain inflammation, also known as edema, and it had to be stopped early. So what did they think? Okay, so this didn't work. Now let's go on to generate some antibodies against the amyloid and see what happens. Okay, so that's what Eli Lilly did in 2006, and concomitantly Pfizer did this with this other medication. So these two antibodies, solanezumab and bapineuzumab, were two trials that in total they had a pretty good group of 5,000 people, but in the end they found out there was no improvement in condition versus placebo, and there was some apparent improvement for mild disease. So yeah, initially they tested this against basically mild, moderate, and severe. So what they did now, they actually went to check. A post hoc analysis is an analysis that just gives you the idea that, okay, this might actually work, let's make a new study. So they made this new study, but they actually found that even in the mild population, there was no improvement. So this was basically putting the amyloid hypothesis almost in the coffin. And of course, we always have to mention from now on the additional difficulties or ethical difficulties, and also news that happened in the 2022, which was after this article was published in the journal Science. So I'll just summarize this for you. This article named Blots on a Field is telling us about two doctors, mainly this doctor, last name Lesnay, and his collaborator Asher, who basically seem to have doctored or manipulated Western blots. As you can see right here, this is like the main image they put on the article, where these two look exactly the same, meaning that they might have rigged the information to generate this article, which was saying that this specific type of oligomer or type of amyloid A beta star 56 was associated with cognitive decline / Alzheimer in rats. So this would pave the way towards trying to attack this specific oligomer and generate trials against it. But yeah, in the end, this oligomer isn't even easy to generate in nature. It's not even found easily, and no one has been basically able to isolate it. So it's interesting, but I don't think this actually puts a nail on the coffin of the amyloid hypothesis, because this was one of so many different articles and investigations showing that the amyloid hypothesis probably is a thing. Of course, this is pretty bad because it can alter the public's perception about all these billions of dollars going into investigation, but it probably won't alter the amyloid hypothesis. The only thing is that we haven't found a real answer to this. So they kept on trying. They thought that maybe the solanezumab and the bapineuzumab were attacking amyloid that was already in the brain. What if we stopped the amyloid from actually forming altogether? They did that, and that didn't work. So then came Merck, and Merck did another trial with 2,000 patients, and basically it was verbesistat, which once again didn't work. So then came a new medication, new injection. This is an antibody against a soluble amyloid called aducanumab, and in this case they did it a little smarter, because they chose the mild phenotype Alzheimer population. So they are trying to put their chips in the winning side, because previous investigations have shown, or did show, that there might be improvement if you did this in the early Alzheimer's or mild Alzheimer disease. But interestingly, this generated a whole lot of problems because although it was the first drug to actually reduce plaque burden in the brain, it wasn't hand in hand with clinical improvements. Yeah, it reduced the plaque burden, but it didn't improve the patient. And what was done is that even if when this happened and a phase 2 trial showed that there were very important adverse reactions, as you can see here, 35% of patients had significant brain edema and half of those had hemorrhagic or bleeding in the brain. Even despite that, the FDA tried to fast-track approval for this medication for early Alzheimer's. And there was a panel of 11, and 8 of the 11 asked FDA not to approve, but in the end, the medication did get approved by the FDA. So you can investigate a little more of this elsewhere, but aducanumab is one of those medications we have approved for Alzheimer. Will you give it for your patient? It's up to you, right? I've already given you some interesting information. So there are other drugs seeking approval. Donanemab is undergoing trials, and lecanemab was recently approved. Lecanemab is the medication I was telling you about earlier that came in the New England Journal of Medicine edition, final edition for 2023, showing that it is a promising medication, and I think it was done pretty well. Lecanemab is another antibody made against the soluble amyloid, and this one does show reduction in the plaque burden, but this time it shows the important thing we were all waiting for or looking for, improvement in the clinical aspect of the patient. How much was this improvement? I'll let you decide, but it is a significant improvement. So it is a statistically significant improvement based on the 3 to 4 scales that were used. So this is good, and this is also in the mild phenotype of Alzheimer's. Okay, so does this fit our patient? No, it doesn't fit our patient because our patient didn't have mild disease. But of course, we cannot go through this lecture without noticing this medication that you're going to probably be hearing about in the future. So in general, this trial was pretty well powered. They thought things through pretty well. There are some limitations. For example, if you tell me that you have a patient who is African American and has Alzheimer's, can they use lecanemab? I'd be a little hesitant because look at this. Only 2.5% of these persons in the trial are black or African American. So think it through, right? Think through if you would give it to a African American. But other than that, the pretty well selected group or treatment group and control group, there are no special statistically significant changes between the two. And there are some other limitations. For example, these were followed only 18 months. So we're waiting to see what happens in the future because Alzheimer isn't something you will just receive treatment for 18 months. It's something we would expect you to receive treatment for years, right? Something else we would like to emphasize is this. We'll see it soon, but for example, serious adverse events, quite similar, 14% in the lecanemab group versus 11.3% in the placebo group. Judge for yourself, it's maybe almost a 3% difference. Of course, you have to go through what are these serious adverse effects, and some of them are pretty important, but don't include death. To be honest, the placebo group had more deaths than the lecanemab group. Infusion-related reaction, that's something to consider. You can see 26.4% for the lecanemab and 7.4% for placebo. And this is important for us to know nowadays. It's amyloid-related imaging abnormalities with edema or effusions. So this is known as the acronym ARIA, A-R-I-A, which is these imaging findings that might be adverse effects with the treatment. So here you can see a pretty significant difference. So we'll just try to zoom in on these differences, and some interesting things I'll go through with you is this ARIA, right? Amyloid related, inflammation in imaging with microhemorrhages or hemosiderin deposits, 14% versus 7%. So that's something to take into account. But even more important to me is that usually Alzheimer is associated genetically to the ApoE gene. And look at this. If you have more of the ApoE gene, you seem to be more at risk, because if you are homozygote, meaning that you have a double, by your 2 parents, you have the ApoE E4, epsilon 4, you have a 9.2% of this area E versus 0% on the placebo group. And compare that if you don't have the ApoE at all. It's 4%, it's 1.4% versus 0%. So it looks like if you have the ApoE epsilon 4, take things into context, because it would be important to determine if you are more at risk of the medication or not. Once again, I am underlining here the ApoE non-carrier versus the homozygote. Whole different ballgame, right? Very much associated with more of these imaging findings, microhemorrhage, and all that for you to consider. So in our friend, if he was to get this medication, I would probably consider, let's first see your ApoE. How much do you have? If you don't have any, okay, probably would be better because you would be safer. If you have a lot of ApoE, watch out a little bit more. And there are already studies that tell us that the ApoE increased amyloid beta deposition in the imaging, and this might be associated to more plaque burden, and this might indirectly tell us that these patients, even if they are doing the same on the CDR score scale or clinically seem phenotypically mild Alzheimer, maybe they are not even mild, maybe they are moderate at least. So that's to consider. Watch out. So the FDA did grant Leqembi or lecanemab approval, which was expected July 2023, and we believe that's a good idea. Just take into consideration those caveats. But I want to mark out some important things to wrap up this lecture. So remember that it's always important to think out of the box. This Dr. Rudolf Tanzi mentions that there's a possibility that the amyloid accumulation in the brain might be there actually to protect the brain. So what if the amyloid is actually there protecting the brain and there's something else that is generating the inflammation that we haven't actually targeted that well? Could Leqembi be helping us with that, or does just this only trial of lecanemab say that the plaques are the whole problem? Probably not. We have to see what the future will say. So we have to take that into account. And also, Dr. Dale Bredesen has written a book also about thinking of Alzheimer as polygenic over monogenic. Think of it as, yeah, maybe Alzheimer is affected by other things we aren't even considering. So that will take me to this last portion, which is recently published 2022 Association of Ultra-Processed Food Consumption with Risk of Dementia. Look at this. This is 72,000 persons without dementia at baseline. They were followed for approximately 10 years, and 518 developed dementia. If they didn't eat many processed foods, the risk was 9%. But of those who ate the most processed foods, the risk of developing dementia was 30%. So there was a clear association that for every 10% increase in consumption in ultra-processed foods, there was a 25% increase in the risk of dementia. Then we have this other multi-center trial, which was published December 5th, 2022. This was a study done in Brazil in 6 different cities, and public servants were evaluated. This was between 2008 and 2017, and there were a whole lot of people recruited, around 15,100, but in the end only 10,700 analyzed, which is a lot. And they evaluated the consumption of ultra-processed foods in quartiles, and it once again is showing association. So in conclusion, higher daily energy from ultra-processed foods associated with cognitive decline, and of course it supports limiting ultra-processed food consumption due to the cognitive harm. Is this new information from 2022, or is this something that has been in the works for more time? So that leads me on to this article in 2008, and look at this. Maybe you have never heard of this term, which is type 3 diabetes. Okay, so since 2008 and a little before that, people have been in the research and the community have been calling Alzheimer type 3 diabetes. This is strong. You have type 1 diabetes and type 2 diabetes. Most of you don't know about type 3 diabetes. So it's basically telling us, hey, this problem going on in the brain is diabetes, and it is the manifestation of diabetes in your brain. So that's powerful. And this was published 2008, and this seems to be holding in time, because look at that, in 2022 ultra processed foods are in the mix, producing problems. 2022, another big article. So we have this one from 2008 and 2020, once again mentioning type 3 diabetes and its role, implications in Alzheimer's disease. So this is for you to think of Alzheimer's disease as something that is possibly polygenic. It's not only your genetics, it's not only your age, it's also what you're doing with your life, your lifestyle, and other decisions that are going on. So back to our friend. Okay, so back to our friend, a individual into his late 70s with advanced Alzheimer's. How can we help him? Well, there's no guidelines. Look at this guideline. I had never seen a guideline retired. So this guideline was even retired. It was one of the main 3 generators of any sort of guideline for Alzheimer's. So there's no clear thing to do. And as you can see right here, this is me with my friend. I took a picture of my recommendations I was giving him because we had breakfast that day, and it was one of the last days I saw him, maybe the last time I was able to share breakfast with him. And I tried to actually give him this, hopefully like a recipe for improvement. So I gave him all these recommendations. I recommended him diet and lifestyle, which we'll talk about a little more in a second. And here he is reading the recommendations I gave him. And of course, he lived alone. He never remembered these little pieces of paper I gave him upon me asking him. And it was a pretty difficult case because he didn't remember it because of his disease. So we basically tried to help our friend in this stage when basically the illness is too advanced, versus this stage where the amyloid plaques and tangles are just starting to form. This is when you have to actually attack it early on prevention, versus down the road, 10, 15 years down the road. So what could we actually, well, our friend passed away about some months ago. He stopped answering my calls, and in the end someone told us that he passed away. I don't have the exact information, but I believe that is the case. And every so often I call his phone expecting to see maybe get an answer, but I believe he passed away. So what else can we do? We shouldn't take these moments lightly. Whenever we have a family member that is forgetting things, we should actually, that's where we should act. That's where we should pay attention. These senior moments aren't times to just ignore what's going on and just try to make up excuses and just try to rationalize, because sometimes the patient will rationalize why they forgot the car keys, why they forgot this, why they forgot that. So if you are their family, if you are their friend, yeah, you shouldn't hate on them, you shouldn't expect more of them, you should try to help them, you should try to detect this on time, try to actually see what can be done, try to maximize whatever can be changed. Because if you wait till your doctor diagnoses Alzheimer's or cognitive decline, it's gonna 5 years are gonna pass, 10 years are gonna pass, because whenever you start forgetting these things that your family knows, like, this isn't normal, something is going on, it'll take your doctor 5 to 10 years to actually realize it. Because when you take your family, you can take your family member to the doctor early on, and many doctors will be like, no, but I see him fine, he's fine. But no, you have to actually think in terms of, how is he for you guys? Has he been like this for the past decades or not? Or is this new? Etc., etc. So you have to make sure you find a good doctor and someone who will actually work with you early on. And these recommendations are from the Massachusetts General Hospital, and this is basically what we have to stress the most on doing early on. So shield your brain against Alzheimer's. So every letter of the word shield means something. Sleep, handling stress, interaction with others, exercise, learn new things, and diet. That is going to be very important. There are several articles on each of these different topics and cognitive function. And that's the basis. I believe that for future guidelines on the topic of Alzheimer's, these should be the first ones, Class 1A recommendations, because that's what should happen in the future, and that's what they will discover. You'll see it in the future. But basically, this is a brain care score. This is the QR code, so you can use your phone, you can scan that, you can do the questionnaire and actually see how you or your family member is doing, and that is a good start. I believe that one of the most respected hospitals in the world, Mass General, is actually leading the way pretty well, because they're covering the bases, right? They're not ignoring this and just saying this is age and genetics and you need a shot. They're saying we have to detect this early on, we have to first try preventing and then do what's best. Okay, and I'll leave you with this last quote before leaving. Your mind and body and brain today are the results of your choices and habits yesterday. Your mind, body, and brain tomorrow are the results of your choices and habits today. And this is from a lecture from Dr. Tansey, so thank him for it. And here you have all the links if you want to see any of these. And that's it for today. Hope you have a great night, and I'm going to try to get my sleep. So see you in the next one.